Hello everyone participating in 2021 SIGMED 4. I am Shin USHIRO. I'm a physician in Kyushu University Hospital in Japan, and I work as a patient safety officer on the front line of medicine. And I also work for Japan Council for Quality Healthcare, which carries out hospital accreditation in my country. The JQ, Japan Council for Quality Healthcare, is one of the institutional members of ISQA, where I work as a board member, and I also work for the Japanese government. In my talk, I'd like to discuss improving diagnosis systems to report error for learning in blame-free culture. So let's get started. Okay, let me briefly describe my workplace, which is Kyushu University Hospital. Kyushu University Hospital is located in the city of Fukuoka, with a history transcending 100 years, like your hospital. And we have more than 3,000 staff members. And the number of beds exceeds 1,400. Kyushu University Hospital is one of the oldest national university hospital in my country. Well, I also work in Japan Council for Quality Healthcare as a dual assignment, which is built into 1995 to initiate hospital accreditation in my country. JQ is funded by Japan Medical Association and the central government and other organizations related to healthcare. Obviously, JQ is one of the organizational members of ISPO as well as in accreditation bodies in other countries. Here I listed the JQ's projects on quality and safety improvement. Here you see a hospital accreditation, and obviously we have two different reporting and learning system of medical institutions and community pharmacies. And we also have obstetric compensation investigation and prevention system for brain damaged baby called the cerebral palsy. And please note that patient representatives participate in most of the projects for co-creation. I know that one of the topics to be highlighted in this forum is diagnostic error. And diagnostic error has been highlighted not only in my country but also in other countries. For instance, we have a textbook on diagnostic error. What you see here on your left is a textbook published this year, including a couple of very famous diagrams, which originally comes from the report on diagnostic error by NASEM in 2015, the National Academy of Science, Engineering, and Medicine of the United States. So as seen here, the report from NASEM is frequently quoted, not only in my country but also in other countries. So I would like to get into this report from the next slide. He is Professor Hardip Singh of Baylor Medical College, who is a great contributor to the US report. We share the same interest on patient safety and quality improvement. Well, this is the definition of diagnostic error that we employ in a textbook in my country. It reads that diagnostic error means the failure to establish an accurate and timely explanation of the patient's health problems, or the failure to communicate that explanation to the patient. I like this definition because it emphasizes that diagnostic error is not only just a matter of accuracy, but also the matter of communication. The report includes schematic diagram on diagnostic process. Well, in the first place, patient experiences health problem and they visit hospital or clinic. In other words, patient engages with healthcare system shown here, and in which we see patients. And we gather information from patients. And what is very important at this point is to collect sufficient amount of information through physical examination, diagnostic testing, referral and consultation, and clinical history and interview. And the information we obtained is integrated and interpreted to produce working diagnosis. diagnosis. In order to get more correct and accurate diagnostic, we repeat this process. And finally, we communicated with patient on the diagnosis and health problem, and we begin treatment to patient. And the treatment will give us more input to information gathering. And finally, we see many types of outcomes shown here. And I'd like to get deeper into the steps of outcomes in the next slide. Well, to begin with, I'd like to emphasize that the diagnostic process is multifaceted and collaborative work affected by diagnostic team members, tasks, technologies and tools, organization, physical environment, and external environment. And when it comes to outcomes, we may see accurate and timely diagnostic, and we may see diagnostic errors and near misses. Both of them give rise to patient outcomes and system outcomes as well. System outcomes effects on quality and safety, cost, efficiency, morale, public confidence in the healthcare system. So we need to learn from diagnostic error, near misses, and accurate timely diagnosis to improve diagnostic process. Okay, once again, external environment is composed of, for instance, organization, physical environment, tasks, technology and tools, and diagnostic team members, teamwork. Therefore, the report states that the committee concluded that sole focus on diagnostic error reduction will not achieve the extensive change necessary. A broader focus on improving diagnosis is warranted. For instance, the report emphasized that we need to facilitate more effective teamwork in diagnostic process among healthcare professionals and patients and their families. And it states that pathology and radiology are critical to diagnosis, but professionals in these fields are not always engaged as full members of the diagnostic team. So it emphasizes that we need to enhance collaboration among those medical professionals. Then the report presents initial 5 goals for improving diagnosis and reducing diagnostic error. If I pick up keywords from these 5 goals to save time, number 1, more effective teamwork. Number 2, education and training in the diagnostic process. Number 3, health information technology. Number 4, learn from and reduce diagnostic errors and near-miss events. And number 5, establish a work system and culture that supports diagnostic process and improve diagnostic performance. Well, in relation to learning through reporting system, the report states that conducting analysis of diagnostic errors and other case events presents the best opportunity to learn from those experience and implement changes to improve diagnosis. Therefore, there is a need for a safe environment without the threat of legal discovery or disciplinary action to analyze those events. So in other words, we need to build blame-free reporting system and psychological safety in our working environment. The U.S. report touches on medical liability. I like this point because it is closely related to my daily activity in my country. It states that the core functions of medical liability are to compensate negligently injured patients and to promote quality by encouraging clinicians and organizations to avoid medical errors. However, the current approach for resolving medical liability claims sets up barriers to improvements in quality and patient safety, as is often the case in other countries, including my country. While medical liability is broader than diagnostic errors are the leading type of paid medical malpractice claims that doesn't improve diagnostic quality. Well, the statement continues. Traditional medical liability reforms have not been effective in compensating negligently injured patients or deterring unsafe care. Alternative approaches are needed that enable patients and clinicians to become allies in making healthcare safer by encouraging transparency and disclosure of medical errors. These reforms can enable prompt and fair compensation for avoidable injuries while turning errors into opportunities for learning and improvement. Having said that, the report presents three more goals for improving diagnostics. If I pick up keyword, reporting environment and medical liability system that facilitates improved diagnosis through learning. Design a payment and care delivery environment that supports diagnostic process. And lastly, but not the least, funding for research on diagnostic process and diagnostic errors. Well, I believe that you are aware of many important goals for improving diagnostic quality. And here I'd like to pick up two goals, two topics to be highlighted in my talk. Number one, reporting a learning system that works in blame-free culture. Number two, establish a medical liability compensation system that promotes improvement in healthcare quality and safety. I picked up these two topics because they are closely related to the project I have been engaged in my country. When it comes to current reporting and learning system in operation in my country, there are two different types of reporting and learning system, both which are internal level, in other words, institutional level, and external level, and in other words, national level. I'm in charge of both of them. Now there are roughly four different reporting and learning systems in operation in my country. The first one is for the system for medical institutions. The next one is for pharmacy. The third one is very unique because it covers only cerebral palsy, brain damaged baby. And the last one only covers accidental death case. Well, I'm going to describe reporting and learning system for medical institution and community pharmacy. Okay, let me briefly describe the outline of our reporting and learning system, which is original one. And we receive adverse event and near-miss event through web-based reporting system, and we occasionally make on-site visit to medical institutions to collect further information. And this system is operated by steering committee and expert panel. A steering committee includes patient representative for co-creation. Our products are listed here: annual and quarterly report, monthly alert database, and we also provide a training program in which participants learn root cause analysis. Our products are totally open to the public on our website on condition of anonymity. Well, having learned that the original reporting and learning system worked very well in my country, in the JQ and the Ministry of Health launched equivalent system for medication safety in community pharmacy in 2008. Most of the element and their functions are identical to the one which is shown in previous slide. From this slide onward, I'd like to focus on a reporting and learning system for medical institutions. There are more than 1,000 institutions participating in our reporting and learning system. Some report adverse event on mandatory basis or on voluntary basis, and some report near-miss cases. So removing the overlapped institutions, we have 1,500 institutions registered in our system. One of the hospital group which is subject to reporting to JQ is a National University Hospital group called JANUHA, where I work. JQ has been closely cooperated with JANUHA for successful reporting and learning system. This is a group photo taken on occasion of annual meeting of JANUHA to observe the very first WHO World Patient Safety Day in 2019. And this slide is to show you the steady rise in the number of reporting to JQ. And we have carried out this system based on two principles, such as a no-blame principle and anonymity principles. We believe those principles are the primary cause for successful reporting. We regularly publish this annual report and quarterly report, which contains outline of the reporting system and numerical analysis and thematic analysis. I'm going to get deeper into thematic analysis from the next slide. Here you see the list of recent themes we took up. For instance, wrong pickup of a syringe filled with therapeutic solution, adverse event and near-miss event related to pathological test, which obviously causes diagnostic error. And another themes that may cause diagnostic error is the failure to confirm CT and MRI imaging report that suggests of hidden cancer or potential cancer. As the failure to confirm CT and MRI imaging report has been very much highlighted in Japanese society over the couple of years, we published a thematic analysis and a monthly alert on this issue as well. And we received many cases on this issue that are obviously diagnostic error. So I will show you the case reported to our reporting and learning system on this issue. What happened was that patient diagnosed with abdominal aortic aneurysm underwent CT scanning for following up the possible growth of it. Vascular physician recorded the finding of the CT image on medical chart on his own. 1 year later, nephrologist, another physician in charge of the patient, learned from another hospital that the patient developed lung cancer. Reviewing the CT imaging report issued by radiologists 1 year ago, it described as there is a lesion highly suspicious of lung cancer, but vascular surgeon 1 year ago ignored it. Well, Japanese media highlighted this issue again and again. What you see here is one of the big media report, which reads, the physician in charge ignored cancer in organs that he or she didn't specialize in. CT imaging reports mentioned 2 cancer. 9 similar cases, including 2 fatal cases, were verified through internal investigation of this university hospital, which is very prestigious Chiba University Hospital. Preventive measures should be in place in expedited manner. This is the story of this media report. In response to the growing concern on the failure to confirm the report, JANUHA conducted a questionnaire survey and on-site survey in 2017 and this year to address this issue. Well, in the questionnaire survey in 2017, one of the questions was, is physician reminded of the new issuance of imaging report when it is produced by radiologist? And it turned out that only 58% institutions are installed with no notification system on issuance of the imaging report on electronic health record. So physicians need to keep the CT taken in mind, not to fail to refer to the report. This could cause an error, obviously. So the notification system rapidly spread in the alliance in our group during 2018 to 2020. Well, to be very honest with you, in relation to the themes of this conference, we experienced painful court ruling in 2019. The event took place in 2006. What happened was that physician in my university hospital overlooked a finding in CT imaging report that suspicious of brain tumor in the report. So in 2019, the district court in Fukuoka sentenced my university hospital to be charged of 150 million Japanese yen, corresponding to 1.4 million US dollar, which is a huge damage payment. In light of a stunning court ruling described in previous slide, I urge the hospital director to equip vigilance module in our electronic health record for prevention. And this module is available by any staff and at any time. If you open the module, you will see two different group of patients. The first group is with imaging report which is not confirmed. This is a big problem. And another group is confirmed imaging report. And you will, at the same time, you will see many of other data such as MRI, CT, MRI, X-ray, ID, patient's ID, patient's name, outpatient or inpatient, clinical division where patient is cared, issued date of the report, and the date of order of imaging test, type of report, radiology report, endoscopy report, and pathology report. And you can narrow down the data between two time points from the day and the month and to another day and another month. If it turns out that you have a patient with imaging report not confirmed, what you need to do is to come to the actual imaging report shown here. I'm sorry that most of the data is protected for personal protection, and what you need to do is to confirm this report in the beginning, and then you change the status of the report from not confirmed to confirmed. There is a button to change the status in this module. One of the products of our reporting and learning system is Monthly Alert, which is composed of only 2 pages. On the first page, it includes logo, title, key statement, and what is unique is shown here, which is illustration to facilitate better and instant understanding of the key statement. On page 2, we include case presentations, and the last but not the least, we include preventive measure improvement measures. Well, the monthly alert is delivered to Japanese medical institutions through a couple of channels such as fax and notice by central and local authorities and the website. Now it is delivered to nearly 6,000 Japanese medical institutions, accounting for 70% of Japanese hospitals. We provide a database of the adverse event and near-miss event for enhancing transparency and sharing individual cases for research use or practical use. You can choose adverse event or near-miss event or both, and you can insert a keyword of your interest. And you will see many cases matched after the search, and among 100,000 cases. And you can download the individual cases of your interest onto your computers into 3 different forms of digital files such as XML, PDF, and CSV. When you download individual cases of your interest, the digital file could be opened through Microsoft Excel. Each line indicates individual case, including coding data and text data. And you can use this file for research use and practical use as well. Our database is welcomed by researchers. There is a research group composed of international researchers, including myself in my country, that aims at applying artificial intelligence to analyze near-miss event and adverse event to create a new knowledge. Well, next I'd like to describe huge change we have brought in medical liability compensation system that promotes quality improvement in diagnosis. Well, this is sort of a reporting and learning system for brain-damaged baby called cerebral palsy, which was launched in 2009. We provide no-fault compensation, monetary compensation paid regardless of negligence, and we also provide investigation and prevention with patient representatives for co-creation. Specifically, we publish and deliver investigative report not only to medical institutions but also to families so that the family will know what happened during the delivery that eventually caused the cerebral palsy. And through this activity, we aim at prevention, early settlement of conflicts, and improvement of quality. Well, here you see the statistics of eligible case by birth year. In the first year, in 2009, we approved 419 cases. The figure declined over time, and we were satisfied with it. You may want to know why the figure shown here in 2015 resurged again. This is because, as I told you in the immediate previous slide, the eligible criteria was expanded in the year of 2015. Okay, once the case is approved in review committee, it moves forward to the next step, which is investigation. We get a lot of information from childbirth facilities shown here, including records, laboratory data on device and human resources, and the location of the childbirth facility, etc. And we also receive questions or voices from guardians to confirm fact sheet to begin the investigation. And 7 subcommittees and 1 parental committee investigate the case and compile a report with the help of technical staffs in JQ, such as midwives, obstetricians, and other technical staff who measures in legal themes, legal subject. And finalized investigative report is delivered both to childbirth facility and families, as I told you in previous slide, and we disclose it. We disclose the summarized version of investigative report on our homepage on condition of anonymity. We publish investigative report to be delivered both to families and childbirth facilities. The next step is prevention of cerebral palsy. We put hundreds of thousands of individual reports on collective analysis, thematic analysis to produce recommendations. And we publish a prevention report on annual basis to be circulated among professional and academic societies. We learned from our annual prevention report that one of the influential type of error that causes diagnostic error is the misinterpretation of cardiotocogram pattern, CTG pattern, in other words, fetal heart rate monitoring pattern. So we published a textbook on CTG pattern to be circulated among professional and academic societies. And the textbook is available on our website for free. Well, the knowledge we gained for prevention of CP in annual prevention report is incorporated in clinical guideline on maternal care produced by academic societies. So new clinical questions are embedded in the revised version of clinical guidelines with our knowledge. I'm delighted to share with you that we have successfully observed a rapid decline in the number of lawsuits related to obstetrics and gynecology. And at the same time, we enhanced transparency by delivering investigative report to patient and families. So those 2 points are completely inconsistent with the point that is emphasized in the report on diagnostic error published by National Academy of Medicine of the United States that I mentioned earlier on in my talk. There are some takeaways to share with you. Number one, diagnostic error is highlighted on global basis. Number two, we need to establish successful reporting and learning system and medical liability compensation system that promotes improvement in diagnostics quality. Number three, blame-free and anonymity are two primary principles for successful reporting. Number four, we embedded in our healthcare system a no-fault compensation system for preventing cerebral palsy and mitigating conflict through enhancing transparency that has been successful. Number five, we published products such as textbook on cardiotomogram for addressing misinterpretation of CTG that cause diagnostic error. So thank you very much for listening. I'm happy to take questions.